Hello, my name is Ben Ham, and we're going to be talking about IOs. First, we're going to talk about indications. AHA says you can go straight to an IO in cardiac arrest and severe hypotension. So that meaning anytime your blood pressure is less than 70 plus 2 times their age. AHA says you can go right to an IO in these circumstances because it takes too long to start an IV. You can also go to an IO anytime you're unable to obtain IV access, but you still need to give fluids or drugs. Now let's talk about contraindications. Anytime there's a break at or above the IO site, you can't start an IO there because the fluid would just leak out the break in the bone. Another contraindication is a previous attempt in that same site for the same reason as a break, because the fluid would just leak out that previous attempt. The third contraindication is an infection at the site. This is not a direct contraindication. If you're only trained, let's say, in putting an IO in the tibia and you have an infection on both tibias, you could still start the IO over the infection. It just wouldn't be ideal. The same holds true for burns. Ideally, you would avoid a burn, but if that's your only option, you could also go through the burns. So now we're going to talk about some sites. AHA recognizes 5 sites. The first one, the most common one, is your proximal tibia. This one is usually not used on infants though, because the tibia is so small. To find the site, as the picture shows, you go 2 patient finger lengths below the tibial tuberosity, which is the bump just below the kneecap, and then 2 patient fingers medial to that. Your next most common location is your humeral head. This one will be used on your larger children, not your small children and your infants. Like the picture shows, it's going to go in at a 45-degree angle to the humeral head, and also you need to have your arm in a position like this. So that way it puts the humeral head in the correct placement. Another location is the distal femur. This one is mostly used on small children and infants because it's the largest bone in the body. It's kind of the opposite of your tibia. This time you go 2 patient finger lengths above the femoral head and then 2 patient finger lengths medial to that. Now let's talk about your 2 less common sites. One of them would be your distal tibia. 2 patient finger length above your medial malleolus and then 2 patient finger lengths medial. The tibia gets a little bit smaller down there, so the proximal tibia would be a better location. And lastly, the iliac crest. This is a very uncommon IO site, but it is still recognized by the AHA, but it's only for manual insertion, so you would not be using it with your easy IO gun. Let's talk about different IO sizes. There is 3 different lengths. Your red one is called your infant or your child IO. Then you have your middle one, your blue one, that's your adult IO. And then your third one is the yellow one, that's your large adult IO. They're all 15 gauge in diameter, but they're all the different lengths. Choosing the proper length of IO needle. Just because you have a child doesn't always going to mean that you're using the child IO needle. It's very important that prior to drilling, at least one black line is visible above the skin. So as you can see in the picture, the very first thing you do as an IO is you push it down through the skin until you hit the bone. So the picture on the top left has not touched the bone yet, and there's no black line visible. The picture on the right with the blue IO needle is touching the bone, but you have at least one black line that's visible above the skin. That means that the IO needle will be able to get to the center of the bone. Now let's say you did that first picture in the blue on the left and you weren't able to touch the bone and you didn't have a blue line. You did not actually start drilling yet, so that would not be considered an attempt. So placing an IO needle. The very first thing you're going to do is you're going to find your site. Then you're going to pick your right size needle. Then you're going to clean the area just like you would with an IV. Then you're going to stabilize the site that you're going to be using, the bone, with never placing your hand underneath the site. Then you're going to place the IO needle onto the drill, and it's nice, it's magnetic, it holds on by itself. Then you're going to drill until you hear either a popping sound or you get less resistance. Be very careful to not drill too far through where you're either stuck in the backside of the bone or have gone completely through the backside of the bone. Then you're going to remove the drill, the whole time while holding that bottom hub. And then you're going to hold the bottom hub and remove the top part of the needle, which is the actual metal needle part. That will be discarded in the sharps container. Then you're going to flush your site with at least 10 cc's, a rapid, forceful flush to clear out that bone marrow. While you're doing that, you're checking for infiltration by feeling behind the site for swelling. If you have infiltration, stop immediately and you'll have to pick a new site. Then, very important, you're going to secure your IO. Very important to do. And if you have an infant or a small child, even after you secure it, the recommendation is holding that IO needle in place while you give your fluids and while you give your flushes and while you give your medications. They say even pushing a flush through that without securing it can back that needle out and the needle will just fall out, because remember, child and infant bones are not as developed as your adult bones. Lastly, attach your extension set and then connect it to a bag. Lidocaine gets brought up a lot during IO use. It does numb the area around and inside the bone. If you're going to give it, it's 0.5 milligrams per kilogram, and it's flowing the fluid that hurts. It's not the actual IO. They say that's similar to starting IV in the pain level. It's when you start displacing that bone marrow with cool or cold fluids. That's what really hurts. Now, most of the time we're starting IO, it's very time sensitive. So unless you have 2 to 3 extra minutes to spare, you're not going to be able to use the lidocaine. So if you are going to give the lidocaine, it'd be more for those patients that are not in hypotensive shock and are not in cardiac arrest, but you still need to get fluids on or you still need to get medications, but you have a little bit more time. If you are going to use the lidocaine, it's very important that you push it very, very, very slowly to let it numb up that area, but then you're still going to do a rapid, forceful flush after the lidocaine has numbed up the area. It might not take all the pain away, but it should be less painful. Now let's talk about some fluid boluses. You would never just leave the bag open and then walk out of the room and guess like you would with adults. Like, it's pretty easy to give an adult a whole liter or 500 cc's. Kids, it's very specific. Most of our kids are going to be giving 20 milliliters per kilogram over about 5 minutes. The push-pull method is what AHA prefers. It's using a 3-way stopcock, or you can pinch the line below the site or above the site instead of using a 3-way stopcock. Here's an example on the next page, and we'll talk about it. So as you can see, there's a 3-way stopcock. So when you are withdrawing fluid from the bag, you have it off to the patient. Make sure your bag's open. Withdraw your fluid from the bag, turn it off to the bag, onto the patient, and then push your fluid into the patient. Do this as many times as needed to get your 20 mils per kilogram. If you don't have a 3-way stopcock, you can pinch the line to your patient while you're withdrawing from the bag, and then pinch the line above your Luer lock to the bag to give your fluid to the patient if you do not have a 3-way stopcock. But the 3-way stopcock is the preferred method. How long can an IO stay in? 24 hours is the absolute max, otherwise you have a risk of infection. You should use a large syringe to help assist removal with a clockwise rotation while gently pulling the needle out. As you can see in the picture, never rock the catheter while moving, otherwise you can break that plastic housing off and then it's just going to be just the needle that's stuck in there. What if your IO drill fails, your easy IO drill fails? Worst case scenario, if you don't have a backup device like the one shown, easy IO says you can just grab the needle by hand and use it that way. It's not ideal, but if the drill does fail, that is an option you could try. Otherwise, there are the manual devices like the one shown that work very well, so check your crash cart and see what you have available. Broselow tape. This is what we're going to use to get a weight, an estimated weight of our patient, and for drug administration. You measure from the top of the head to the heel how they naturally sit. Call out that color, and that should line up with your pediatric crash cart. Feel free to round up or round down if you have a kid that looks a little bit bigger, a little bit smaller. Round up one color or down one color as needed. The Broselow tape works very well for medications, but you should always still double check your work with either another person, another pharmacist, another app like Pediastat, another book, however you need to do it. You should always double check your work even after looking at the Broselow tape. All right, so now we're going to go to the breakouts and we're going to practice. Let your instructors know if you have any questions.